Good morning and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you doing this morning?
Doing just great. Thank you.
Dr. Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and U.S. COVID statistics through today, November 16th. As always, we invite you to submit any questions you have down below via our Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with the U.S. COVID statistics for this week, average new hospitalizations per day are 2,104. Average COVID deaths per day are 74. And the new vaccine uptake, the 2023-2024 vaccine, is reported by the CDC at 13.9% of U.S. adults and 4.9% of U.S. children. Dr. Murphy, your reactions to those numbers?
They're pretty stable, maybe slightly less than the last couple weeks, but stable. We do expect upticks in all the respiratory diseases due to the travel that's associated with Thanksgiving and the gathering of families from different parts of the country or region, whatever, or even cities. And so typically we have a spike up after Thanksgiving. So that's that. And then we'll see, December is usually the beginning of the flu epidemic anyway. So we'll see what happens through December and January and February are the big months. Okay. The vaccine uptake, this is the new vaccine now. Remember, this is not a booster. You're not getting the same vaccine that you or one of the 5 you've taken in the past. It's a brand new one, completely different, works much better against Omicron. And we're going to have a couple other stories about Omicron that are very important for these numbers. But the vaccine's been out since September, and there's only been a 14% uptake in adults and 5% in children, which is really low. Especially now with the season taking off, the respiratory infection season, it's really important that you get these vaccines as soon as possible. The higher the risk, the more benefit on saving your life exists. So if you're elderly or you have any underlying chronic medical condition, especially anything related to your heart or lungs, definitely get the vaccine. But everybody should take it. Everyone that's eligible.
Absolutely. And staying on the topic of Omicron and COVID infection, there was a study published recently out of Sweden that specifically looked at Omicron outcomes compared to influenza or RSV. We have generally looked into COVID against influenza and RSV, but can you break down the findings of this Omicron-specific study?
Yeah, so we've reported in the past from other studies that have been done that RSV has a more likely chance, if you get that, more likely chance to cause problems. This is a very well-controlled study of over 6,300 patients in Sweden, and they were appropriately diagnosed and tested, and specifically they had Omicron. So it wasn't a mixture of different variants of COVID-19. So the 30-day mortality in this group was 2.5% for influenza, 6% for RSV, and 7.9%, almost 8% for the Omicron variant. And then if you look at the Omicron deaths, unvaccinated versus vaccinated, and it could be any kind of a vaccination schedule, the 30-day mortality adjusted upwards if you were unvaccinated, upwards by a lot, by over twofold. In terms of getting really sick and ending up in the hospital, it was actually more likely that RSV ended ended you up in the hospital. 64% of the ICU admissions compared to 50% for Omicron and 39% for flu. So, these are bad things to have. And I think people have to realize that Omicron, which is circulating now, it can be deadly. People die from Omicron. People are getting Omicron, and some of them are getting very, very sick. This is not to be taken lightly. And as these data are showing, as other studies we've presented in the past, you can end up in the hospital, you can end up in an ICU, and you can die easier from Omicron than the other ones.
Absolutely. And just another reason to stay up to date with your vaccinations. And also moving on, but staying on the topic of, those who are most vulnerable, in this case with influenza, children and the elderly tend to, be among the groups that are largely affected. A new study came out detailing that antiviral treatment against the flu is largely underused in children. Can you break that down for us?
Yeah. So kids can get very sick with influenza. Varies a little bit by age, but they get it and they spread it, and they can be treated though. There's treatment for this, and it's recommended by the American Academy of Pediatrics. And they found that despite national medical guidelines that every pediatrician and pediatric treating person knows, very underutilized. 40%. And the younger the kids, the less they were used, and which is the opposite of what it should be, because the younger the kid, the more risky it is when they get the disease. There was very wide geographic differences. It just depends on the practice patterns in different areas of the country. But that doesn't have anything to do with, whether it works or not work. It works but you have to take it. That's called implementation, and that hasn't happened. Why is this happening? So they think that there's a wide perception about the efficacy. Some people just don't think it's needed. Some people don't think it works. It does. Differences in interpretation of testing, a misunderstanding of the national guidelines, concern over adverse drug events, and the drugs are actually well tolerated. They're treated for a very short period of time. And then, of course, there's cost. It's about $138 per treatment course. Now, most insurance covers it, but if you don't have insurance, that's $138. And it just is another one of these unfortunate things that the country is not taking seriously in something that's so contagious. This is like a public health emergency. And we should have some kind of national plan, which of course we don't. That's really the story. It's just the underutilization. If you have kids and they do get influenza, very easy to diagnose now, treat them.
Absolutely. And we will keep our eye out for any news or grumblings of updated guidelines for using these antivirals to help children. But speaking of different treatment plans for infectious diseases, there's been a lot of talks about Paxlovid. We've reported on it. There's lots of stories in the news, but there was another study that was just recently published that offered more data into the rebound that we're kind of seeing with Paxlovid. Can you break down those numbers for us?
Yeah, we've been, most treatment for COVID is outpatient. So it's not so easy to get data on relapses and rebounds, whatever. So that's one of the challenging parts about this whole disease. But once you start looking closely and thoroughly, you get some real information. So we've reported already that yes, it's maybe up in the 1 in 5 or percent, proportion. And this is just another study that shows that this rebound is about 1 in 5, about 20%. And the very interesting thing about this study, which was, very tightly controlled study, was that the people that treated themselves early tended to be the ones that rebounded, whereas the ones that got treated 2 or more days after the symptoms started, there was almost nobody rebounded. So that tells us a couple things. One is that perhaps people who get symptomatic, and now the diagnosis is so easy to make. They can go to the pharmacy, they can get a test, they can walk into any urgent care place and get a test. All that stuff is very easy to do now, thanks to the rapid acceleration of diagnostics program, RADx, because now there's tests everywhere. There's over 8 million tests done per day. So we should really think and do a study to prove that this is effective or not, of treating longer in people who are starting earlier, not to wait, but to treat it differently. It's kind of a different disease earlier on with the drugs, and nobody knows why that is. We have to figure that out, but studies like this will help us. So, other reasons to take Paxlovid besides keeping you out of the hospital and having you live longer, whether you got vaccinated or not, is you'll spread less COVID if you get treated. And the people that have been vaccinated have typically much lower levels of virus in their system. So that's good too. But the drug works whether you were vaccinated or not vaccinated, whether you had COVID or didn't have COVID. We just keep getting it. It's like the flu. People get the flu all the time, even though they've had the flu before, even if they had the treatment before or whatever. So, but it works, and rebound can happen. I reported my own findings. I started the last time I got COVID, I was a person I had dinner with got COVID and sick. And so I tested myself. I had no symptoms. I took my medication before I developed my symptoms. Great. Then I developed the symptoms and I got sick, but I was already on the Paxlovid. And like 2 days after I stopped the Paxlovid, I rebounded. And I took another course of Paxlovid. But the same thing happened with Dr. Fauci and many other people. I was hearing about. I said it can't be that uncommon. If I know already a handful of people just in my own little circle that have had this kind of rebound phenomenon. So it's real. And if you start early, you're likely to have it, and you may need another course. And but this is just the way this pandemic is being studied, and this is good. We have some hard data now. You shouldn't be surprised. And this information about within 2 days or after 2 days of symptoms is good to know.
Absolutely. And we will, of course, stay up to date and keep looking for more research published on these topics to keep you informed. But staying on COVID, moving on to the vaccines rather than treatment. There's always speculation with new vaccines that it could affect fertility, whether it be male or female. But there was a very large study published detailing the non-effects that the COVID vaccine has on miscarriage. Could you please break that down for us?
Well, this is important because there's been so much misinformation about this, and it's just kind of out of control. This is data, okay? 1,815 women trying to get pregnant were followed. And they found that in unvaccinated women, the miscarriage rate was 26.6%. In those who had one dose or more, it was 23.9%. And if they had the full series with a booster, it was 24.5%. There's no statistical difference between those numbers. So miscarriage was not associated with the vaccine. And it was split between the Moderna and the Pfizer one. And the overall miscarriage rate was 24.5%, which is kind of fits in with the normal miscarriage rate that we understand that happens. It's a big study, and it just shows there's just, again, no difference at all in miscarriage rates due to the vaccine.
Absolutely. And that's very important to note. Shut down that misinformation. The data speaks for itself here.
Right. These are hard numbers. This is 1,815 women and followed.
Absolutely. And I guess piggying back to the treatments for COVID-19, the WHO updated their guidance on treatment for COVID-19. Important to note, the WHO is not the United States, but can you break down what their changes were?
Yeah, so WHO is, recommends the treatment, any treatment, remdesivir, Paxlovid, molnupiravir, any kind of treatment. It's not as available in many countries, especially low and middle income countries. So they have a much broader look at the situation. But it's interesting. They've changed some things. They lowered the benefit threshold down to 1.5%. It had been 6% reduction in the risk of hospitalization. And that's due to the worldwide increase in immunity overall, vaccine-related or disease-related. So that's just kind of interest. And they are kind of breaking it down, the use of it, into focusing more on high-risk people versus just everybody over the age of 50 or whatever, people that just want to take it. Because it's less likely to be available in many places. So they're just being practical. And then there's been a big uptick in the use of a new antiviral drug, VV116, I guess, 16, yeah, which is popular in certain areas. And they're saying that they're against the use of this drug until it's proven in clinical trials, which are ongoing. And lastly, a very strong recommendation against using ivermectin, which is used mostly in horses, and it has no place in the treatment of COVID.
Absolutely. And with all topics, we love to stay up to date. If there are certain updates or different places from around the world that you would like to hear more about their guidelines, feel free to send it in down below and we can do more research on that. But piggybacking into our last story of the day, I may butcher this name. However, there has been reported Leishmania, which is a flesh-eating parasite in the United States, and it may be endemic in some parts of the country. Can you, one, help me with that pronunciation, and two, break down this story for us?
Leishmania, and there's different kinds of Leishmania. We used to only see it in people who've come back from endemic areas, like in Brazil or the Amazon basin area. It doesn't just happen, or used to not just happen in the United States. However, it looks like it's now spreading in the United States, in the southern states. Texas is where this was reported. There's Leishmania mexicana, has now been spreading locally through regions including Texas and along the southern border of the country. It's carried and spread by sandflies, which are even smaller than a mosquito. And after the sandfly bites you and it has it, skin sores erupt weeks to months following the bite from an infected sandfly, and they can last for months to years and lead to scarring. And so what the reason why this is important is that just means Leishmania is now can happen de novo in the United States. And why is that happening? What's with these sandflies? It's why are they coming up into North America now and starting to cause problems? The people that are getting reported with this have not traveled, and they're not recent immigrants. It's people who live here. So most likely it's the same thing with dengue. It's due to climate change. The climate is changing. The planet is warming, and the area that those mosquitoes and sandflies can survive is expanding. And along with that expansion comes the diseases that they can transmit. And so that's the problem here. This is just an example of what we're going to expect. So I think for practicing physicians and clinicians and concerned people about this, if you see something unusual, you have to think in terms of, especially in the southern part of the United States where it's warmer, that maybe this is a tropical disease, and that's not commonly seen here. You've got to put that in the back of your mind as part of what we call the differential diagnosis. So it's just an example. We're going to see more and more of this.
Yes, and that is unfortunate, but thank you for breaking it down for us. And as always, thank you very much for your time and expertise going through the COVID statistics and all of these new published research articles. We appreciate it, and thank you very much.
Thank you.
And thank you all for joining us again this week for the Ask Dr. Murphy series. As always, please feel free to submit your questions down below or at any of our social medias linked in the description. We'll see you next week.